that, I'd like to introduce the program director tonight. He put the agenda together. He'll be the moderator. He'll be fielding your comments and questions. It's Dr. Ralph Verdino, who's an associate professor of medicine at the Perelman School of Medicine at the University of Pennsylvania. He does his internal medicine residency at Mount Sinai in New York. And then he did his cardiology and EP fellowship at Georgetown University Hospital. He joined the faculty of the University of Chicago School of Medicine as an assistant professor of medicine in 1996. And then in 1999, he joined the faculty at the University of Pennsylvania, where he served as the director of the electrophysiology fellowship program for over 12 years. Dr. Verdino is very active in ACC, HRS, and other professional societies. He's on several committees. He's authored or co-authored over 75 scientific papers, and he's lectured around the country and the world. So it's all yours, Dr. Verdino.
All right, thank you, Mitzi. A true pleasure to be here. Again, I'd like to thank Yvonne, who is in charge of the Fellows Program for ZOLL around the country, and also Cheryl, who's joining us today. Again, I'm very impressed with ZOLL. Remember, ZOLL makes the wearable defibrillators, nothing to do with pacemakers and implantable defibrillators and interpretations of ECGs and cases and the like. And they're really very committed to education, and it's truly a pleasure to work with all my friends at ZOLL. They really are committed to fellow education. We built a program tonight. Again, we wish we could, be closer and see each other, but we realize that there's a huge need for education. Everyone is working really hard these days. And unfortunately, education sometimes gets pushed aside in order to, take care of all the other issues that need doing in this time of crises. So we're trying to keep up with education and realize that, pacemakers are something that everyone will see in the field of cardiology, even if obviously you don't go into electrophysiology. Many patients have pacemakers, and knowing who to refer for pacemakers, defibrillators, how to interpret ECGs that have pacing on it is really very important to anyone who takes care of cardiology patients. So we built a program around 3 different sessions. The next one will be on Thursday at the same time, and then Saturday morning. And tonight we're going to focus kind of on the basics. We're assuming you don't know an enormous amount. Those who do, it'll be a bit of a review, but we will build up to that advanced concepts in the next couple of sessions. And for those who really are new to this, hopefully you will really get a lot out of the first talks and stuff, so that you'll do great in the more advanced things in the coming days. I do want this to be interactive. So if you can send me anything in the chat, that would be great. I will interrupt the speakers periodically. A little bit less so for the lecture part, but quite a bit more for the ECG portions. And as you can see, we put in the ECGs after towards the end of each of the 3 sessions. And really the last one will be really cases and EKGs, so it'll be pretty much all interactive. So without further ado, I'd like to introduce the first of our speakers is Dr. Kusik Krishnan. Dr. Krishnan is an associate professor of medicine and pediatrics at Rush University School of Medicine. He did his medical school training at the University of Texas Southwestern Medical School and did his internal medicine residency at Barnes Jewish Hospital of Washington University. He did his cardiology fellowship at Emory University and his EP training back at Barnes Jewish. And he's going to talk to us today about basic pacing concepts, and we have about an hour or so for this. So Dr. Krishnan, it's all yours.
Thank you, Dr. Verdino. Thank you to ZOLL, and welcome to everyone. Let me get this working here. So I'm going to split my talk into 5 categories. First, we're going to talk about just the basic hardware of like what makes up a pacing system. And then we'll move on to slightly more advanced topics of sensing. What does that mean to sense intrinsic activity? What does it mean to be able to capture? How do we see that on an EKG? We'll talk about different pacing modes, and then we'll talk about pacing timing cycles. And hopefully, even though this is fairly basic, it is really fundamental to understanding a lot of the things that are going to come in the subsequent lectures. So let's first move to pacing hardware. So most pacing systems have either 1, 2, or 3 leads, and we'll kind of go through each one separately. So a single chamber pacing system means that you're going to be sensing and pacing in one chamber only. Conventionally, you may see that most often in the ventricle, like what we call a VVI pacemaker. We haven't defined those terms yet, but we will shortly. Occasionally, you may see a pacemaker that only paces in the atrium. And there's different reasons why you might choose a single chamber pacing system. For example, if you're going to be pacing only in the ventricle, likely you don't need to pace the atrium, or you can't pace the atrium, as in someone who's in permanent atrial fibrillation. Atrial pacing is a little more uncommon because oftentimes if we're taking the effort to put in a pacemaker, we'll take the chance that if they develop AV block in the future, we have them protected. But there are patients that truly only have sinus node dysfunction, and all we would really need to do is pace their atrium. And so a pacemaker that's a single chamber ventricular pacemaker would only show pacing in the ventricle, versus a single chamber atrial pacemaker would only show pacing in the atrium. A dual chamber is what it sounds like. There's 2 chambers that are paced. So there will be a lead in the atrium and 1 lead that is in the ventricle. And this allows us to maintain AV synchrony in patients, especially that have AV block, even if it's intermittent. When they pace, you will be able to maintain the synchrony between the atrium and the ventricle, which can be beneficial to many people that need pacing. The implantable pacemaker has multiple components. It has a pulse generator, which is the part that usually sits under the skin. I'm not going to be talking a lot about leadless pacemakers. That kind of brings on a different level of complexity when you think about the pulse generator. But the most commonly implanted devices are going to have an implantable pulse generator that's usually subcutaneous, often in the infraclavicular region, whether it be on the left or the right side. And that will be connected to the intravascular leads that are placed through either a cephalic or an axillary or subclavian vein, conventionally advanced into the heart and then into their desired location. And one of the leads will end in the ventricle and one will end in the atrium. The pulse generator houses the battery and also any electronic circuitry that is needed to determine when pacing is needed, when it's not needed, and also kind of the brains of the pacemaker. The batteries, depending on which company, have different compositions, but they're often some variant of lithium, lithium iodine, lithium vanadium, and they have a very slow but predictable decline over time and can last in upwards of 10+ years in today's iterations of these devices. The longevity of the battery is going to be determined by other factors, not just the natural decay of the battery, but how much current is drawn, and that will be determined by the capture output and how often it needs to pace. For a patient that may pace 100% of the time will obviously use up more energy per day than someone who paces 1% of the time. And those are all factors that will contribute to longevity. The leads themselves, which we know are a weak link, but yet have been the link that we have between the pulse generator and the myocardium for many decades. And these are insulated wires that transmit signals back and forth. They send signals in the situation where you need to pace the myocardium. They also receive signals or transmit signals back from the myocardium to the pulse generator so that the device knows when a patient needs pacing and when they're having their own intrinsic cardiac depolarization, which then would trigger the device to inhibit pacing. There are different kinds of leads. More often than not, these days, we use bipolar leads, and I'll define the differences between those. But there are still going to be some systems that have unipolar pacing leads. They are often a little smaller in diameter because they only need to carry one conductor to the tip of the lead. But they're also going to be prone to more extraneous data that might inhibit pacing. And when you see a pacing spike, you often will see a much larger, more noticeable pacing spike in a unipolar pacing system that you would in a bipolar pacing system. The bipolar leads are a little more immune to oversensing from non-cardiac signals such as myopotentials or electromagnetic interference. So let's talk about a unipolar pacing system. So unipolar pacing system, it's a little bit of a misnomer in the sense that the lead only has one electrode, a cathode, but there is a second pole, and that anode is the device itself. So the bipole of the cathode to anode is very large. And if you think of it like an antenna, it comprises a much larger antenna. So that is why it could pick up signals that are more far field versus the more near field signals that are generated at the myocardial lead interface. So when a pacing impulse is generated, it goes to the tip or the cathode and it enters the myocardium and creates a depolarization, but the current then flows back to the anode, and that is the circuit that comprises the unipolar pacing system. And so I did ask this one question, we'll see how, why might it be important to know if you are changing out a pacing system, for example, to know whether this is a unipolar or a bipolar pacing system in someone. I'll give you a little more information that this is a patient who's pacemaker dependent and you're doing a pacemaker generator change on this person. If there's not a lot of interaction, that's fine, but I'll give a few seconds to see if anyone wants to chime in on why it would be important for you to know that piece of information before starting the procedure.
Yeah, it looks like we have so far one person has a thought saying once the can is out, you lose the circuit.
Excellent. That's correct, and that's important. And I always, when I'm training fellows, probably once or twice a year, we have a unipolar. We may not have a unipolar pacing system that was placed, but sometimes the device automatically switches to unipolar pacing, or maybe during follow-up, we found that there were some lead issues and the unipolar pacing was more reliable. And so I will sometimes see if the fellows recognize that before, and I won't let anything happen to the patient, but I'm always kind of waiting to see if they recognize that something happened when they started taking the can out of the patient's body.
So also
good. So
if you have a good anesthesiologist or not, right?
Yes. So when you take the pulse generator out of the pocket, it's now exposed to air, and the current can't go through air to finish the circuit, so you'll lose pacing. Another trick you can do here is either you place a temporary pacemaker if you need to, or if you wrap the pacemaker pulse generator in a lap or a sponge that's wet, and the half of the pulse generator is outside of the body, but the wet lap is placed partially inside of the pocket, that will still form the circuit, and you'll be able to keep pacing going without losing pacing. So that's a little kind of a tip and a trick to keep a unipolar pacing system to continue pacing even when physically the device is outside of the pocket. So that's the circuit. So in a bipolar pacing system, the cathode and anode are geographically very close to each other. So the circuit is between the cathode and the anode, which is usually only a centimeter or two behind or less behind the cathode. So the location of that circuit is very discrete and geographically in a close area. And so when the can is not needed for the circuit, so you can take the can out of the pocket and there won't be any loss of pacing. And because the antenna is much smaller in size, something that is much further away from the heart muscle is less likely to be sensed and lead to inappropriate inhibition of pacing. Now, leads, whether they're bipolar or unipolar, come in different types of fixation, and they come in either passive or active. More often than not, now you will see active fixation, but there are still situations and implanters that prefer passive fixation or timed leads. So in the top image here, you have a timed lead. So there is no active fixation mechanism. So those little celastic grappling hook-like appendages get fixed into the trabeculation of the RV myocardium or the RA or right atrial appendage myocardium and create a kind of a fibrotic reaction and keep the lead in place that way. Whereas the active fixation mechanism is a helix or a screw that starts off, in some leads, starts off housed within the distal end of the lead, and then through a mechanism, a screw mechanism on the back end of the lead, the screw can come out to the end of the lead. Now, there are fixed screw leads, and the one that is used a lot these days if you do His bundle pacing is the Medtronic 3830 lead, which has a screw that's already outside of the end of the lead, and you have to turn the lead in order to fixate that mechanism. So there are some advantages and disadvantages of each of these types of leads. When you're placing the lead, you have more options for locations with an active fixation lead because you can put it up against a smooth walled structure, but because the fixation is a screw. Whereas the passive fixation mechanism is going to be a little more challenging if you don't have trabeculation to catch the tissue. In addition, when you're extracting these leads, if you're in an extraction center, if you talk to people that extract leads, active fixation leads are generally considered easier to extract because sometimes when you unscrew the lead, unscrew the fixation mechanism, that may be enough to release it from the myocardium, or at least release a significant amount of it to where there's less force needed to remove the lead, and there's less of a fibrotic reaction at the end of the lead. All of these leads these days often have a steroid at the end of the lead, which helps to reduce some of the initial fibrotic reaction that tends to increase pacing thresholds. And so the pacing thresholds tend to be a little more stable at implant than they were before steroid-eluting leads were invented. And that's just a little bit of steroid at the end of the lead that helps prevent your body's natural reaction to fight off this injury that's occurred at the myocardial interface. And finally, epicardial leads, which are less likely for us as cardiologists or electrophysiologists to implant, but your surgical colleagues are still going to use these and may still be used a lot in pediatrics where the length of a lead and the growth of a human as they grow as from a child to an adult can play a role, or in patients where they are high risk of infection, you may end up using epicardial leads. So these are placed on the epicardial surface of the myocardium, which obviously necessitates access to the epicardium. That can be done through a small mini thoracotomy, thoracoscopy, or often sternotomy. The different types of insulation that are used can also differ from manufacturer to manufacturer. They can be silicone, they can be polyurethane, or they can even be some blend of the two. And they have different biochemical and material science properties that make them advantageous. Their strength, their ability to be extracted, their resistance to damage, to solute and electrolytes. These are all factors that are each of the different manufacturers will kind of promote as advantages to the insulation material for their product. The reality is all of these insulation materials eventually tend to fail and when they fail, they can lead to electrical abnormalities in the leads. So now let's move on to some of the actual properties of when we place these leads and these devices. What are we trying to achieve, and what are we trying to avoid happening? So it's important to understand a little bit about kind of electrical engineering and physics of current flow. And so obviously Ohm's law is familiar to most of us that remember freshman physics, or if you've taken any engineering courses. So V equals IR, V equals voltage, I is current, and R is the resistance or impedance. So some people find it easier to understand electrical properties as fluid dynamics because that's a little more visual and you can see it. So voltage is kind of like the faucet being turned on, and current is the flow of the electrons or flow of electricity, and impedance is the resistance to flow. So if it's a pipe that has fluid going through it, if there was an obstruction that would prevent the flow of that fluid, the impedance is also that impedance is what prevents or resists current flow. And there's always going to be some resistance. It's just a matter of how much. And that will contribute to current flow. So if V equals IR, I is equal to voltage divided by resistance. So the higher the resistance, the lower the current, with the voltage being the same. So these are things that can impact battery longevity because all of these factors will impact current flow. So capture threshold is defined as the minimum amount of stimulus or energy that is needed to consistently capture the heart. So here on this screen here, we have a V, a pacing stimulus followed by a QRS, pacing stimulus followed by QRS. And to make it easier, I'm showing you what the pacemaker is annotating here. This would not be seen on a surface ECG. This would only be seen when you are interrogating a device. So VP stands for ventricular pace. So ventricular pace, ventricular pace, ventricular pace. The device here tried to pace here as well, but there's a difference. This V pacing stimulus is not followed by a QRS. So this would be a non-captured stimulus. So what can affect capture? There are acute and chronic factors that can affect capture. This is primarily related to what's happening in the device, in the lead, and at the interface between the lead and the myocardium. So we'll talk about the lead myocardium interface. So if the lead is not making good contact with myocardium, that there's inefficient current transfer to the myocardium, which will prevent capture. What if the lead is making good contact with the tissue? What could impact capture in that respect? And that is, you are expecting that the current that's flowing from the end of the lead to be in contact with excitable cardiac tissue. If there is non-excitable tissue or scar, if you place the lead in a position where there was a prior myocardial infarction, there may be unexcitable tissue there. So you may have great contact, but the contact is with tissue that no amount of current or a very high amount of current is needed to cause those cells to reach their action potential point of excitability. Steroid, as I mentioned, is one way to decrease the ability for that interface to prevent capture. So most leads that are now on the market have a little bit of steroid at the end that prevent the acute stimulation threshold from going up too high, because you don't want the lead to be pacing when you place it in someone who's dependent, and then 24 hours later, when they're in their room, they lose capture because the threshold went up to a very high amount, and then you have inadequate output to stimulate the myocardium, and then they may go asystolic or have a very slow escape and have syncope. So myocardial capture is a function of the amplitude of the voltage output of the battery and the device, which needs to be large enough to cause depolarization or capture. And we also have a pulse width. These are the output of the device is an amplitude and a duration of that voltage being supplied for a certain amount of time, and that is called the pulse width. So we can achieve capture multiple ways. We can achieve capture at a higher voltage with a shorter pulse width. We can also get capture with a lower voltage and a wider pulse width. And that defines what's called a strength duration curve. So we can test output of a device for capture at multiple pulse widths and keeping the voltage constant, or we can keep the pulse width constant and check it at multiple voltages. And we can create a curve, which is called a strength duration curve for any patient. And we can then decide what will achieve capture. And then we can also create a safety margin, because we don't want to pace the cardiac muscle at exactly the amount that can lead to capture, because there could be electrolyte changes. The lead, at least initially, could move a little bit, and you want to have a safety margin so that you don't lose capture. So here is an example of what we call a threshold check. So we have kept the pulse width constant at 0.5 milliseconds, and we are decrementing the voltage output from 1.25 to 1 to 0.75, and then down to that should be 0.5. So the question I have for you is, what voltage output would you define here as capture, the capture threshold? Remember, that's the voltage output that consistently leads to myocardial capture.
Yes, if you can vote in the chat. So we have a smattering here. It looks like most people are kind of saying D at 1.25. We have a few that are saying C at 1 volt. So
very good. That's the point of this question, and most people picked the two that I was hoping they would pick. So remember, it has to be consistent capture, and at 1 volt, this is where it changes to 0.75. So here at 1 volt, we do have capture for 3 beats, but here there's a V pace, but we don't see a QRS after it. So we don't have consistent capture at 1 volt. But at 1.25, there are 4 pulses given, and all 4 have resulted in capture. Whereas at 1 volt, 3 out of the 4 pulses have resulted in capture. So here, the capture that results in consistent capture, the output that results in consistent capture is 1.25. So now let's move on to another important concept, and that is, we can pace all the time, and that's great, and we can figure out outputs, but some patients don't need pacing every single beat of their life. And we need the device to know when it's appropriate to pace and when it's not appropriate to pace. And that's the concept of sensing. Sensing is what is the ability of the pacemaker to see when the patient has an intrinsic or natural depolarization occurring. And they need to sense that signal. And so when we place a lead up against the myocardium, before we determine if we like that spot, we will check sensing. And we check it by seeing what is the millivolt amplitude of the signals, the intrinsic signals that the patient has. Now, sometimes you put a pacemaker in a patient that has no underlying output, and you may have a temporary pacemaker, and in that sense, you're going to be sensing a paced stimulus, but most of the time we're looking at an intrinsic stimulus. So here's an example of a 0.5 millivolt signal, and here is a larger amplitude signal. Here, there's an important concept that we accept different sensing values depending on the chamber that we're sensing. So a ventricle has a bigger mass, and the signals that you get in the ventricle are often larger than what you get in the atrium. And because in the ventricle, there's also the challenge of T waves potentially being repolarization or T waves, that we need to have a larger sensing amount because we may need to filter out other signals. And I'll show you some examples of that. In the atrium, sometimes that does also still play a role because depending on where you place the lead, you may sense far field signals from the ventricle that you want to filter out as well. But in general, we want to see at least 1 or 1.5 millivolt signals in the atrium and 5 or more millivolts in the ventricle in order to allow us to set the sensitivity to take out other signals that we don't want to see. Now, sensing, you almost have to sometimes think of it backwards in the sense that when you have a high sensitivity number, here in this example, it's 5 millivolts, that is being less sensitive because you are filtering out a lot more stuff. So here's an example, a poor example of a P wave, a QRS, and a T. And the QRS is going to be the biggest signal that you see in most people. So if you set a sensitivity at 5, every signal in this patient is falling under the radar. At 2.5, everything is falling under the radar except the QRS. At 1.25, the P wave is falling under the radar, but the QRS and the T wave are not. So think of the sensitivity as a fence, and you want to be able to see things over that fence. So something has to be taller than the fence to be able to see it. So if you set the fence at 5 millivolts, you will not see anything until it's at least 5.1 or higher. If you set the fence really low, then lots of things peek over the fence, even things that you don't want to see. So in this example, you will see the QRS and the T wave. So that will lead to the device thinking that it sees 2 intrinsic depolarizations, even though there's only 1. And then if you get the right sensitivity, you get rid of anything you don't want to see, and you only see the thing you do want to see, which is the QRS complex. It may be a little more complex than that, but I think that's the gist of it, because there are amplifiers and things that are also in these devices to try to get rid of unwanted signals such as myopotentials. There's blanking periods that can also be used to get rid of extraneous signals. And we'll talk a little bit about those in the timing cycle part of the lecture. So sensing is determined by obviously having the circuit being intact where the leads are working, that there's no fractures, there's no insulation breaches, that the placement is in a good spot in the heart where the signals are expected to be good, not in the region of scar. And unipolar versus bipolar signals will determine how good the sensing can be. The properties of the myocardium, if you place it in a region where there's been a prior myocardial infarction or in a region next to a valve, you may not see as good a signal as you would in other areas of the myocardium.
Krusek, we do have one quick question. And I think it's one. What do you mean when you say acute and chronic with sensing?
That's good question. So when we place a lead, that's the acute period. So when the lead is up against that myocardium, we know that we can measure those signals at that moment in time. But that interface between the lead and the myocardium could change over time. And so that could be a normal reaction that your body has to form scar tissue. It could be just an inflammatory response that could affect the sensing signals. And oftentimes when you place active fixation leads, there's actually injury to the myocardium because you've actually screwed in a little metal screw into the myocardial tissue. And we can measure that. It's called a current of injury. And sometimes that current of injury will dissipate over time and will change the sensing that you see, the myocardial signal that you see. So we know that there may be changes over time, and that's why we like to have a little bit of a buffer when we get the sensing, that even though it may get a little lower over time, if we start off with a good number, even if it drops by a few millivolts a few years later, we're not going to be in any jeopardy of not being able to sense proper signals. It's a good question. So when we see sensing, we can either have under sensing or we can have over sensing. And you have to think of the idea that if you're under sensing, you'll actually have over pacing. So here's an example. In the first beat is a paced beat. And then this red arrow defines the device is going to pace at that lower rate limit of 60 beats per minute. And at the end of this red arrow is another paced beat. But what happens here? So here the patient had an intrinsic QRS that came in before the next pacing stimulus was supposed to happen. What should have happened was that this intrinsic QRS was sensed by the device and stopped it from pacing. But here you can see there is a pacing spike right on the T wave. The device did not see this QRS and it tried to pace. And the reason it didn't capture was because it was in the refractory period during the T wave, so it didn't capture. Now, what about here? This is an intrinsic QRS as well. And this red line is what we call the lower rate limit. If it sensed this intrinsic QRS, it should not pace until here at the end of this red line. That's when a 60 beat per minute rate should have paced. So why would the pacemaker pace here so soon after this intrinsic QRS? Again, over pacing. It shouldn't pace that soon after the QRS because it did not sense it. And I'm showing you the marker channel of the pacer. If it sensed there would have been a marker here that said VS or V-sense. So under sensing leads to inappropriate or over pacing. What about over sensing? So over sensing leads to the opposite problem. That leads to under pacing. So again, here, same example, V pace, 60 beats per minute or 1,000 milliseconds, V pace. That's what the pacemaker should be doing, should be pacing no faster than that. Then here comes an intrinsic QRS, and the device appropriately saw it. It sees V sense. This red arrow, is a 60 beat per minute timer. If it sensed this appropriately, which it did, at the end of this red arrow, there should be a pacer spike there and a capture, but there is not. So it leads to a longer pause here that's much longer than 60 beats per minute. That's under pacing. Whenever you see a pacemaker and you see long pauses and you say, why is this thing at a rate lower than 60 beats per minute? It means it's under pacing. It's not pacing when it's supposed to. And what you can see with the marker channel is that it did sense this beat appropriately. But here is another V sense. And if you go up to the EKG, there's nothing there. There's no QRS, there's no T wave, there's no P wave. So it sensed something, it oversensed something. And then if you start a timer from that point over to here, you can see that it even sensed something else here that it shouldn't have. So oversensing means that it senses something that it's not supposed to be sensing, which leads to underpacing, which leads to a heart rate slower than the lower rate limit. And you may not know what it's oversensing by looking at the surface ECG. Sometimes you can tell, but you will often have to do an interrogation. And even then you can sometimes not really know what it's oversensing. You just know that it's not sensing what it's supposed to it's over sensing something, and which leads to under pacing. So our fourth section here is to talk about pacing modes, and go through this so this is when we talk about DDD, VVI, etc. The first letter is the chamber that's paced. The second letter is the chamber that's sensed. And the third letter is what happens when response to sensing to a sensed event. Is it going to inhibit pacing, or is it going to trigger pacing? Most dual chamber devices are going to be set DDD. Sometimes we'll set DDI in patients with atrial arrhythmias that are tracking that atrial arrhythmia, and we don't want to track that atrial arrhythmia. When we have a single chamber, it's often VVI because it's only sensing one chamber, and it's very difficult for it to actually track something when it's a VVI system. So VOO is another common pacing mode. You'll see this when you have sent a patient to surgery, for example, and they're dependent and you don't want electrocautery to inhibit pacing. VOO means paces the ventricle, but it does not sense anything, any chamber. So it will just pace at a fixed rate, and we want it to do that because we don't want electrocautery to prevent pacing. So there's no sensing. It's just asynchronous is another term for VOO pacing, and it will pace at the rate that you set it to, and it will never be inhibited by anything extraneous. VVI, it will pace until it senses something that tells it it needs to inhibit. So that third letter of I is what happens when it senses an intrinsic activity. I means it inhibits pacing. So here it's V-pace, V-pace, PVC, inhibits pacing, and then it finally paces when it needs to. DDD is a little more complex because you have two leads, and they're going to be working together. So the atrial lead will be sensing what's happening in the atrium. The ventricular lead will be sensing and pacing in the ventricle. And so you can, DDD means it senses, it paces in both chamber, which is the first letter. It senses in both chamber, which is the second letter, and it can inhibit if there's intrinsic signals, or it can track if there's a sinus tachycardia or an atrial tachycardia. It can track that atrial rhythm in the ventricle. So when you see an EKG for DDD, though, remember you can have 4 phases of DDD pacing. You can have intrinsic rhythm and not see any pacing whatsoever. That you may not even know the patient has a pacemaker if you saw this. You can have an atrial sense and a ventricular pace. So you can see A sense, B pace. You can see A pace with intact AV node conduction to the ventricle with no V pacing. So you can have A pace and a V sense. And you can have the situation where you have sinus node dysfunction and AV node dysfunction and have AV pacing. So don't be fooled. You can have any one of these EKGs and still have a normally functioning DDD or dual chamber pacing system. And the final letter, which is often an R, DDDR, is rate response. So some people with sinus node dysfunction, even though you put a pacemaker and solve their lower rate problem, that they'll have a heart rate of 60, that may not allow them to thrive, because physiologically, when they exercise, they're not going to have a faster heart rate because their sinus node doesn't work. So these modern pacemakers have a rate response feature. And these rate response can be either due to motion, which is usually a piezoelectric crystal that is sensitive to motion of the body, or it can be a physiologic, like a minute ventilation, where it's sensitive to breathing and changes in respiratory or transthoracic impedance. And a lot of devices now have blended sensors because each sensor may have their own Achilles heel of what makes them not be able to appropriately detect motion. For example, a motion sensor requires motion. So if you're on a stationary bike and your upper body doesn't move very much, your motion sensor may not sense motion and may not appropriately augment the heart rate. In the contra example, if you are sitting in a car and you're going on a very bumpy road, your body is moving, but you don't need more of a heart rate at that motion because your device doesn't know that your motion is due to the car moving, not because you're running or walking upstairs. And so there's different, the blended sensors tend to offer kind of a check and balance where if one sensor doesn't sense motion, the physiologic stimulus to offer rate response, but the other one does, it will kind of look at the two together and say, you know, maybe I need to look at both of these pieces of information to determine whether to increase the rate. So we choose a type of pacemaker based on whether we're looking at a patient with sinus node dysfunction only, AV block only, whether or not they have permanent AFib, in which case we don't need an atrial lead. And you can see this in the syllabus, but we can go through this tree determining whether or not a dual chamber pacemaker or a single chamber is needed, and then whether or not we need to turn on rate response or not. And finally, in the last 5 minutes, we'll talk about timing cycles.
Interrupt a minute.
Yeah.
I want to get to a couple questions. You know, if we go over a little bit, it's not the end of the world. We have a couple good questions. The first one, and they're both a little bit related. Can you explain a little bit about the risk of R on T pacing if you set someone at VOO? And then kind of as a corollary to that, you know, which is the best way to set someone's device, let's say when they're getting surgery or having an MRI scan?
Very, very good and excellent question. So yes, when you place someone VOO, you do have the risk that there could be pacing on a intrinsic QRS. So we tend to make people VOO if we're confident or reasonably confident that they're pacemaker dependent. In that scenario, it's unlikely they're going to have any intrinsic QRSs for us to have that R on T phenomenon. So if a patient is not pacemaker dependent, this could vary from institution to institution, but we often will not program them VOO because of that concern. And we will often have our anesthesiologists and we give them a magnet and say that if on the unlikely event that during the procedure you have bradycardia and you need pacing, a magnet will almost every device, the magnet will make the device go into VOO or DOO mode as long as the magnet is physically over the pacemaker device. So our anesthesiologists know that they can do that. And so there's a magnet there, they can put it on top of the device. And if they really need to, they can even tape it on that. So a lot of times when we get called and our nurses get called, we will counsel them that if we look in their patients that are in our system and we know they're not pacemaker dependent, we often will not put them VOO, and we'll counsel the anesthesiologist that if you have issues during the case to put a magnet on the device. And some places will do that anyway and not permanently reprogram them VOO, because the downside of programming someone VOO is that you have to go back later and program them back to their original settings because the device has been permanently programmed VOO or DOO. So a magnet has the advantage that if you just remove the magnet, they go back to their original setting. So yes, for MRIs and for situations where you need to keep pacing and you know someone needs pacing, then we will make those changes. But you do have to be careful when you set someone DOO or VOO in the setting where they have intrinsic conduction, because you might get that R on T phenomenon. And, you know, I'll open this to the other faculty members. I mean, I know it's a risk. I'm sure I've seen it a rare amount of times, but I don't think it happens that frequently, but we don't really want to take chances.
Yeah, I mean, I'll be honest and say it really doesn't happen with permanent pacemakers or on T pacing. You're right that it's the vulnerable period, but remember, before we had kind of these very sophisticated devices that we can check over the telephone, we used to actually do telephone checks of pacemakers where the person put the magnet on and we were able to actually see how much battery is in there, because pacemakers actually pace at a specific rate depending upon their model for how much battery is left in the device. So that was our way. Now, you get it remotely and it's very easy. But remember, if that was a problem, then all these people would be, having torsade or dropping dead on the telephone, and that really wasn't a problem. The only time I've really seen it is really if electrolytes are way out of whack or with a temporary pacemaker. Remember that when we put a temporary pacemaker in someone, you kind of crank up the output of the device because we're always afraid of losing capture. And certainly in intensive care units and things like that, where electrolytes are a little abnormal to start with, I have seen pacing on top of T waves in kind of a VOO or a non-sensing mode that has actually caused that. So it is quite rare. So again, great questions. So some of these ones, we may get to a little bit later. And if not, if we don't have the time, then I may answer some of them online. But I think we should probably move on to the timing cycles.
Great, thank you. So timing cycles are trying to understand the brains of the device, like what is the device thinking and what is it not thinking. And I like to explain it to my fellows that you have to really think of the pacemaker as just a series of timers that get turned on and off. And there are very specific things that make the timer start and stop, but it's over and over and over again. Those timers are just starting and stopping, starting and stopping. And the question is, when do they start? Why do they start? What makes them stop? And what are those factors? So a single chamber system is probably the easiest to understand the timing cycle because it's just one lead. It doesn't have another chamber that it needs to sense off of or sync to. So we set a lower rate limit, which is also a lower rate timer. And the easiest one to remember is 60 beats per minute. That tends to be a conventional lower rate limit. It happens to be 1 beat per second, and 1 second is 1,000 milliseconds. So you can understand very simply that after a device paces, it's looking to say, I cannot let this heart rate get below 60. And that means that I'm going to look for any intrinsic activity for the next 1,000 milliseconds. And if something happens before 1,000 milliseconds, that means that the rate is higher than 60 beats per minute. And so it starts another timer and says, I'm just going to start another timer and another timer. If it does not see anything in that 1,000 milliseconds, then that lower rate timer has expired, it paces. So that will allow, you will never violate the lower rate limit of 60 beats per minute. If it sees intrinsic activity, it says, okay, the heart rate is above 60, I'll start another timer. So it's a beat to beat monitoring, not an average of 60 beats over a minute. It's literally every beat has to be 1,000 milliseconds after the last either pace beat or the last intrinsic QRS. So here, V pace, lower rate timer, 1,000 milliseconds, didn't see an intrinsic beat, so it paced. 1,000 millisecond timer starts again, and it sees a V sense. Starts another 1,000 millisecond timer after this V sense, didn't see a QRS, and so it V paced. There's also something called a refractory period that's also going on in the background because you want to get past the QRS and the T wave. So you don't want it to sense something too soon after a paced beat. So that's the ventricular refractory period, and that exists either after a sensed or a paced beat. So that's considered kind of more simple. Now the dual chamber devices have other timing cycles that we have to factor in. So we have an atrium and we have a ventricle. We have a lead in the atrium, we have a lead in the ventricle. And what we're trying to do is we're trying to maintain AV synchrony and a physiologic sort of PR interval analog. We call it an AV interval in a device, but we're trying to kind of mimic the normal PR interval of an intrinsic sinus node beat that has to depolarize the atrium, get through the AV node, get through the His-Purkinje system before you depolarize the ventricular myocardium. So we have a lower rate timer again, but it's now going to encompass an AV interval and a VA interval as well. So, but we still don't want the lower rate to go below whatever we set it to. And if it's 60 beats per minute, that's 1,000 milliseconds. So the lower rate timer will begin after an A pace or an A sense. And ultimately, we want the next intrinsic beat to not be any slower than the lower rate of 60 beats per minute. Now, we also have to add in the AV delay now. So even though we have this lower rate cannot be less than 60 beats per minute if we're setting it at 60, we now have to factor in that there is an AV delay that is going to be part of that lower rate timer. So after an A pace or an A sense, there's going to be an AV delay timer. So again, remember, the concepts are just timers getting started and stopped. So this AV delay timer is what we set it to. We might set it at 120 milliseconds or 160 milliseconds. We might set it differently if it's a sensed P wave versus a paced atrial beat. But whatever it is, we set that number, and we set it at, let's say, 160 milliseconds. And what's happening in that 160 milliseconds is the device is looking to see, did that atrial depolarization, whether it was paced or sensed, make it through the atrium, make it through the AV node and His-Purkinje system, and result in an intrinsic ventricular depolarization. And if that AV delay timer expires and there is no QRS, it will pace in the ventricle. So there are even other timers that get started. So after the ventricular pace, there's something called the PVARP, or post-ventricular atrial refractory period. Again, a timer that we can set. Now, there are auto PVARPs, but we can also set the PVARP. And that is so that after a ventricular beat, we are going to blind the atrial lead to any activity so that it doesn't try to sense something like the pacing stimulus, for example. So the PVARP is a period of time that's defined where the atrial lead is blinded, so to speak. There's also something called, so this is what the PVARP is, an atrial refractory period after a paced beat or a PVC that does not start any atrial timer. It's important for a couple of reasons, and that is that anything that happens during the PVARP in the atrium will potentially get counted for mode switching, which is something we didn't discuss. So the device is looking in the atrial channel to see if you're going into AFib or AFlutter or an atrial tachycardia. So it can count that information for purposes of mode switching, and it'll keep track of that. But in essence, it is going to be a blinding period for the atrial channel. And it's meant to prevent, if there's retrograde conduction after you pace in the ventricle, it goes back up to the atrium. If we didn't have the PVARP, the atrial channel would sense that retrograde atrial beat, trigger another ventricular beat, and essentially go into an endless loop tachycardia that's called PMT, or pacemaker mediated tachycardia. Nowadays, a lot of devices have algorithms that know that PMT is occurring, and it will automatically extend out the PVARP further and further and further until that atrial beat falls in the PVARP which means then the atrial channel doesn't see it, and then it stops the PMT. But if the device doesn't have an auto feature to do that, the way that you would do it is either put a magnet on the device, which then switches it to a DOO mode, or you interrogate the device and you can manually extend the PVARP so that you can make that retrograde atrial activation be blind and the atrial lead won't see it any longer. So again, so we have an AV delay, a PVARP, a lower rate timer. There's an atrial refractory period as well after an A-paced or an A-sensed. And this is to kind of prevent re-triggering of other atrial events during kind of a refractory period, if there's extraneous signals or if you don't really want anything to happen in the atrium right after you've paced. So there's kind of a defined atrial refractory period as well. Ventricular refractory period we mentioned as well. We want to kind of get past the QRS and the T wave. That will prevent double counting of QRSs because you count the QRS and the T wave. You don't want that to happen. So there's a ventricular refractory period as well that begins after either a paced beat, a sensed beat, or a PVC. So I know it gets a little complicated here because I'm kind of drawing in all these different timing cycles that are happening, some of which are more important than others to understand, such as the AV delay, the PVARP, the ventricular refractory period, and the lower rate timer. But it's important to understand these things or know that they exist, because sometimes that is the reason why you will have function of your device that may seem like it's malfunctioning when it's really not malfunctioning. It just may be something that is inherent to a blanking period that you just may need to adjust in order to make the device work properly. And the final one that I want to talk about is something called the ventricular blanking period. And this is to prevent what's called crosstalk. Sometimes when the atrial lead is placed close to the ventricle near the annulus, that if you didn't have this ventricular blanking period, the ventricular lead could sense the atrial pacing spike. And if it does that, and you didn't have this ventricular blanking period, the ventricular lead sees that pacing spike and says, whoa, I don't need to pace because I see a signal. It doesn't recognize that that signal is crosstalk. It's something coming from the atrium, and then it won't pace in the ventricle. And if that happens, then you could have no pacing. And in someone who has AV block, that could be catastrophic. So remember that ventricular blanking period as well. So I know I went over a few minutes. I apologize. Hopefully that was useful. And I'll, if you want to take questions now, I'm here. If not, we can do it at the end or offline.
We are getting a couple questions here. One thing, we can field one or two and then maybe go a little over. Can you tell us a little bit about the ventricular blanking versus loss of capture? So how would you distinguish that it's just blanked, or is it not capturing?
Well, on a surface ECG, you wouldn't necessarily be able to tell that, because all you would see is there'd be no QRS. But if you did an interrogation of the device often will annotate that with like a VB. So it's telling you that it saw something in the outside of the blank, in that blanking period, and that's how you would tell. Some of the devices have something called safety pacing. I didn't get into the safety pacing because if it's called safety pacing, at least for like a Medtronic, for that precise reason, is that it says, well, what could be happening in this ventricular blanking period, that there's two things that could happen. One is crosstalk, which is that the ventricular lead sees something from the atrial channel, and in that scenario, you would want pacing to continue. The second thing that can happen in the ventricular blanking period is a PVC. and intrinsic PVC. And so in that scenario, safety pacing, it paces in the ventricle at a narrower AV interval than what you set. And oftentimes it's like 100, 110 milliseconds, which is shorter than what you would have set the AV interval. And you will know that because you will see on the surface ECG, you'll see, why do I see an A pace and a V pace at this very narrow interval that isn't the paced AV delay? So the reason safety pacing occurs like that is that there's two, as I mentioned, there's two things that could happen. If you safety pace at a short AV interval, because there was crosstalk, it will capture the myocardium and you will never lose ventricular pacing. If it was a PVC, that pacing stimulus will happen in the middle of the QRS because it's happening so early after the A pace. And if there's a PVC in that blanking period that's preventing pacing, you're going to see that pacing stimulus right on the QRS when it's refractory, when it's not dangerous at all. So it's kind of like a no-lose situation for the pacemaker. Either it was crosstalk, it will pace at a short AV interval, capture the myocardium, prevent no pacing, or it will pace on a QRS and there'll be no consequence. So the pacemaker doesn't know which of those two things happened. You can figure out which of those two happened because you'll see a PVC or you won't see a PVC. But for the patient, they will not lose capture.
Great. Okay, excellent. Okay, so we are going to move on now to our second lecture. And I would like to introduce Dr. Ali Shakir. And Dr. Shakir is a clinical assistant professor of medicine at Wayne State University. He's also the medical director of the arrhythmia services and the EP lab at Henry Ford Maycomb Hospital. He did his medical training at Aga Khan University in Karachi, Pakistan, and did a master's in academic medicine at the University of Southern California. He did his internal medicine residency at the University of Texas in Houston, and cardiology and electrophysiology at Henry Ford Hospital. And he's going to try to bring some of a lot of the complex concepts that Dr. Krishna did so well explaining to you guys in kind of some rhythm strips and talking about the basics. So Dr. Shakir.
And you guys can hear me now?
Yes.
Perfect. So that was a great initial talk on what the pacemaker sees, right? So what's the device actually seeing? What's the device's terminology? And so that's a good way of looking at that. What we're going to do the flip part of this talk is when you're actually looking at the EKGs and trying to figure out what the pacemaker is doing. So we're really going to focus on what you see on the EKG, and we're going to work our way back to the terminology. So kind of the objectives of today's talk will be one, so we'll appreciate the importance of identifying the device and underlying rhythm. So two concepts, right? So knowing that what type of device the person has and what the underlying rhythm is. Understand basic pacing and sensing functions on what, when you're seeing on an EKG strip, trying to figure out what's going on with the device. And mechanisms of pacing and sensing malfunction. And then finally, some application of principles with some cool cases. So I don't know if you guys probably have realized by now, but EP, we're kind of like the nerds of cardiology. There's all this different terminology. There's all this new language. It's completely different than the other cardiology, interventional. So it's a lot of these terms. And so Dr. Krishna went over all these terms, and you have to know these terms. You have to know these definitions. Otherwise, you are not going to be able to understand devices. You will not be able to understand rhythm strips. So it's really important to understand those basic terms. So, you know, when you're going to go look or evaluate a patient or evaluate a patient's rhythm strip, ideally, it'd be nice to know a few things when you're looking at that strip. You want to know, what kind of generator is it? Is it a pacer or is it an ICD? Because that'll kind of give you a hint of how it's programmed. You want to know if it's a single chamber, a dual chamber, a bi-V, and that'll also give you an idea of what to expect when you're looking at the rhythm strip. Many manufacturers have different quirks. So at night, it's very common for somebody with MVP mode, Medtronic, for example, where they'll miss a pacing because they're trying to minimize ventricular pacing. So it's important to get that manufacturer to know what specific modes certain manufacturers have. Current programming, try to know the date of implant. Is it acute? Is it chronic? That'll kind of help you if the leads have recently been manipulated. Try to know the indication for the pacemaker. Is it for sinus node dysfunction? Is it for AV block? Medical and cardiac diagnoses will kind of help you. Are there severe electrolyte disturbances going on? And that's why you're seeing some of these rhythm strip abnormalities. And again, with recent medical procedures, was the patient programmed to a VOO mode? Was there an MRI done? Was there any electrocautery done near the device? Was there any trauma? So those are all things that you would kind of, before you even go and see the patient or you see a rhythm strip, you want to know these things. And the more information you have, the more the benefit or the easier it'll be to go through the rhythm strip and figure out what's going on. So step one. So, Dr. Krishnan went over knowing what the pacing chamber is, what the sensing chamber is. So is it programmed to DDD, DDDR? However it's programmed, so those are the common ones that we usually see. But again, it's really important to know how it's the program setting of the pacemaker. And then you want to look at what's consistent with what shows up in the rhythm strip. So step two. So after you find out how the device is programmed, you want to look for what is the underlying rhythm, right? And at the same time, you want to see what's going on in the atrium and what's going on in the ventricle, right? So if you know what's going on in the atrium and you know what's going on in the ventricle, that'll kind of help you try to figure out what's going on with the pacemaker. So if somebody, I kind of, you guys, we've been listening to us talk the whole time and kind of chatting in the box. Can I call on some people that I know that have kind of typed in, maybe Dr. Frankel? You want to go through this strip for me?
Sure. Can you hear me okay?
Perfect. What do you see?
So, I mean, towards the end of this strip, it looks like we're seeing kind of P waves. It looks like sinus there. Kind of early on, not really seeing any P waves. Looks like you have a ventricular escape rhythm at somewhere in like 30-ish range.
So perfect. So the first beat, what do you see?
Yeah, so the first beat, I mean, I'm just kind of seeing a little bit of like a wide complex that looks different than the next set of complexes. But I'm like not seeing any clear pacing. Oh, actually that first beat looks similar to the QRS complexes at the end of the strip.
So the first beat looks similar to the QRSs in the second part of the strip. So you see at least a QRS on the first beat. Do you see a P wave in the first beat?
No, I don't.
No, you don't see a P wave in the first beat. So that must be a
junctional
rhythm. Perfect. Okay. So you got a junctional rhythm followed by a wide QRS rhythm, right? Which is probably some idioventricular rhythm, which is slow, right?
Yep.
That comes through. So it's important you did multiple things there. You saw what there was atrial activity, you saw what there was ventricular activity, and you saw that there was a change in morphology. So those are all the things that you need to do. So just like you're looking at somebody with a pacemaker, you want to actually know what's the underlying rhythm, what are you dealing with? So underlying, so then you know what the pacemaker is trying to figure out. So if you can figure out what's their underlying, that'll help you to figure out what the pacemaker's saying. So perfect, right? So you want to know what the underlying rhythm is. Okay. Let's see. So terminology-wise, right? So Dr. Krishnan went over some terminologies, basic pacing and sensing terminology. So refractory period, right? So the refractory period is when a sensed event does not reset a timer, right? So the device sees something, but its timer is not because, hey, it's occurring way too early, right? Sensitivity, again, is programmable. It's that fence that he talked about, right? So the fence is programmable. You can put it up, you can put it down, but you something that you can program on the device. Sensing is what the device sees, right? So the device can see a P wave, it can see a QRS. So sensing is described in millivolts, right? So what is the P wave activity? What's the QRS? What's the device seeing? Blanking period. So the device's eyes are closed. It's not looking. It doesn't want to look. So immediately after, so the common one is post-ventricular atrial blanking, right? So after that, after the ventricle, it does not want to see, right, what's going on. The atrium does not want to see what's going on. Tracking, right? So whatever the device, whatever's happening in the atrium, you want to follow along in the ventricle, the device is going to track that. And the threshold, the minimum amount of stimulus, right? So these are all terminologies that most of you guys will probably be accustomed to, and Dr. Krishna went over some of the basic definitions. So step 3. So when you're starting to look at the rhythm strips, right, you're saying what's going on? Is pacing occurring at the proper rate? And if it's not, why? And is pacing occurring at a faster rate or a slower rate than expected? So who wants to handle this? What do you guys see? Sophia? I'm just going to go down on my screen. I know my kids always hate me. They're like, "You're the teacher that calls on everybody throughout these Zoom lectures." Other fellows kind of hate me as well.
So it looks like we have a ventricular beat, and then you have a pace beat that comes right after the T wave. So it looks pretty early. It's at a rate of close to like 75. So if the lower rate tracking is below that, then it's an early beat. So it's probably over sensing something. At least that's what I could tell from that. And then again, there's another beat coming in that's paced. I don't see an I don't see a P before it. Actually, no, it looks like it's P. It's A paced, I mean. And then it's QR sensed. But again, it looks pretty early on. So it looks like maybe there's a, I'm not
So
sure.
if we are going to assume, so just like when I give you a strip, the first question you should ask me is this a single chamber or a dual chamber pacemaker, right? So that'll help you kind of figure out what's going on. So if I tell you this is a dual chamber pacemaker, what does that tell you? What does that help you in any way? So I want to know from the atrium, do you have any atrial sensed activity?
No, there's only a paced activity.
Perfect. That's perfect, right? So you can't comment on any atrial sensing, right?
Yeah.
Because you don't see an intrinsic P wave. If you don't have an intrinsic P wave, you can't comment on atrial sensing. So you don't know what sensing is going on in the atrium. How about pacing?
So I see there's the second and third beat are A paced, and there's a pace at the end.
And so pacing is occurring properly. Maybe the rate's a little faster. You don't know how it's programmed, but at least pacing is occurring and capturing is occurring, right?
Yes.
You see that the P wave is being captured. And how about ventricle? Is there any ventricle sensing happening?
So it's hard to
go ahead.
Sorry. It's hard to tell if it's sensing the ventricular activity here because of, I mean, if it's supposed to be pacing at that high of a rate, then after that second pace beat, there's nothing on for a while until that QRS, until that the ventricular escape beat comes out. So it looks like something happened to the pacemaker that it decided not to pace at that time. So that's why I thought it was oversensing something.
Is there any sensing occurring?
It's hard to, I'm not sure.
So look at the beat that, at least when you see atrial pacing, right? In the atrial paced beat, right? And then you have atrial capture. If it was a dual chamber pacemaker, the ventricle has to have seen that QRS,
Yes.
right? Narrow beat. So because it saw that and didn't see any ventricular pace, but you don't see any ventricular pacing throughout. So you have a hard time, but you're going to make an assumption that after atrial pacing, at least, it would have seen something, and that's why it's not necessarily ventricular.
Yeah.
You're probably making an assumption. But I see what you're saying. But other times, the rate becomes so slow that either something is going on where there's oversensing, and that's why you have underpacing. But at least you get some idea. Again, you want to look at the atrium. You want to figure out what's the atrium going, what the underlying rhythm in the atrium is, what the underlying rhythm in the ventricle is. And then you can look at each lead, looking whether sensing is occurring properly and pacing is occurring properly. So as long as you have the same systematic process and looking at these strips, you'll be able to figure things out. So that's perfect.
Thank you.
Next slide. So just like we're trying to figure out, is there sensing, right? You want to figure out, is there capture, right? And so we saw on the strips before in Dr. Krishna's talk that we were looking at pacing happening and seeing what the device sees when there's no capture. And now we're going to look at what you see on the rhythm strip when there is no capture. And so if you follow along here, right, you can see that there is a pacing spike happening, right, without any ventricular activity, right? So there clearly is loss of capture. So again, the spike that you see should be followed by depolarization of whatever chamber for good evidence of capture, right? So you want to look at where the spike is, expect what chamber the spike's coming from, and figure out where the captures happen. Okay, so if there is no capture, right, you want to know, is it because of true non-capture or functional non-capture? So what does that mean? Who wants to help me next? Who's next on the list?
Here. I've been nominated to answer this question.
Awesome. Fair enough. Yeah, the beer that helped me that way. I know Mitzi, something in the background. My mouse is kind of acting up. Sorry, guys, for a little bit. I don't know why. But okay, keep going. Who's next?
Yep. So with regard to non-capture, looking at this strip, what stands out to me is that the first two pace complexes fall within the duration of the T wave during a period when you would expect the ventricle to be refractory. So I would say that corresponds to functional non-capture in that circumstance. Some of the other pacing spikes fall at phases where you might reasonably expect capture to occur. So I think the third one, that to me represents true non-capture. As to the subsequent ones, I will say actually 4, 5, and 6 occur at phases where you're already seeing intrinsic conduction go through.
So what's the difference between true non-capture and functional non-capture? So just like refractory period, right? So just like if the ventricle is in a refractory period, right? So if you remember the action potential, and if you send, depolarization in the middle of an action potential, and the ventricle is not ready to depolarize, right? That'll be something of a functional non-capture. Versus if the ventricle's ready to depolarize, right? Then you know that's true non-capture if the spike follows. So for example, if you look at the third spike, like you said, it's after the T wave, from there you should probably capture the ventricle. Even the fourth spike, if If you look at right on top of the P wave, the ventricle should at least capture there. So in this case, right, you have episodes where some spikes are true non-capture. And on the other hand, if you look at the first, second, third, fourth, fifth spike over when it happens right on top of the QRS, or the sixth one, you can see that there's no way the ventricle is going to be ready. So in that case, you have functional non-capture as well. Okay, so in this slide, you have both true non-capture and functional non-capture. Just depends on the timing of when the pacer spike's delivered to figure out which of those two it is. Does that make sense?
Yeah, absolutely.
So true non-capture, right? So if you know that, the patient just had the pacemaker put in and goes to the floor, and you see that, hey, that there's spikes happening without any capture, you want to think of, is the lead been dislodged, right? Is there a loose set screw? Something was done during the case. On the other hand, if you see somebody who's had the pacemaker for a long time, and then they're still having episodes where there's pacing spikes without capture, is there any type of lead dislodgement, like a Twiddler syndrome? Somebody took the device out, twiddled the leads out. Was there progressive fibrosis, right? Talked about before that steroid-eluting leads. We usually don't see this too often. Is there myocardial infarction? Is there some metabolic or drugs or electrolyte abnormalities going on? Is there a damaged lead, like insulation failure or a lead fracture? Or is there any battery depletion where it's just not delivering enough energy and capturing the heart? So if you have true non-capture and the patient's got AV block, you know that you have to do something soon. Otherwise, you're going to get in trouble. Make sense? Okay, so functional non-capture. So when pacing stimulus occurs in the physiologic refractory period of a native depolarization, it will not capture, right? So if you look at that circled beat, right? So the pacing spike happens right after the QRS. So you know that there's no way that that's going to capture. And really the two causes, right, of functional non-capture, it's the other hand, right? So you have true undersensing, right? So it's not seeing the QRS, the ventricle's not seeing the QRS and delivering spikes everywhere. So in that sense, you have true undersensing. Or if you have a long refractory period for some reason or the other, where it's not going to capture. Those are really your two causes of functional non-capture. So step 5, is there sensing, right? So to make it a case for accurate sensing, it is necessary to find intrinsic ventricular or atrial events, right? So we talked about that on the first slide where we were guessing whether it's a dual chamber and what's going on. So it's nice to see both the atrium and it's nice to see the ventricle. And if you see both of those things, then you know. So who wants to take me through this slide? Who's out there? Did Juan go yet, or Michael? Maybe out there.
I guess I'm the only Michael.
Perfect. Yeah, good.
Right, so let's see. At the beginning of the strip,
Yes.
seeing some what seems to be native complexes. Seems to be native P's. I mean, I don't know what lead we're looking at, but I see P waves and narrow TRS complexes without pacing spikes in the beginning. By the 4th QRS, but by the 4th complex, I'm seeing a pacing spike, probably atrial pace.
Okay.
Then right after that is another atrial pace. Again, atrial pace and then a V pace, which continues until the end of the strip. So a V pace towards the end of the strip, A pace in the middle, native complexes in the beginning.
So now I want you to think about what is the device seeing, right? So this is a dual chamber pacemaker. So what is the device seeing in the first 3 beats? So you said it perfect. You see in the first 3 beats, you got a P and a QRS, P, QRS, P, QRS. So what's the device's annotation when Dr. Christian showed on the thing on the strips and what the device is seeing. So what's the device seeing? If you printed out a rhythm strip from the device, what would it be seeing?
Well, so it's seeing that native P, so it's not producing a P spike. It's not producing an A spike. Sorry. So I would.
What are the first 3 beats? What's it seeing?
It's I mean, it's seeing a native heart rate, heartbeat it doesn't have to intervene on because it's seeing periods throughout. It's seeing sinus rhythm basically. It's seeing.
Say that one more time.
It's seeing P wave QRS complex.
So it's in P waves and QRS. So we would say it's in atrial sensed, ventricular sensed, right?
Yes.
Because you do not see any pacing in the first 3 beats.
Right.
Right. So in that sense, the device is seeing the atrium properly. It's seeing the ventricle properly. So it's A sensed, V sensed for first beat. The second beat, again, A sensed, V sensed. The third beat, A sensed, V sensed.
Yes.
What's the fourth beat?
Fourth beat is not seeing, it's not picking up an atrial sense.
So what's it doing?
So it's pacing, the atrial pace.
A paced.
And then it's sensing a
ventricle, right? So it's A paced, V sense. So if you printed a little strip out, the first 3 beats would be A sense, V sense, A sense, V sense, A sense, V sense. The middle 2 beats would be A paced, V sense, A paced, V sense. Does that make sense?
It does.
You follow? Sense, right? So the device, you know that sensing is happening correctly in the atrium and the ventricle, and in the middle beats, you know that pacing is happening. And is there a capture there? Is there atrial capture?
Atrial capture? I mean, I see a blip that's inverted compared to the prior period.
So you see a little blip afterwards, and something conducts down to the ventricle. So you know that the A pacing is occurring properly. So perfect. So now you've proven sensing happening in the atrium and ventricle properly. You've proven pacing happening in the atrium properly. And now the last 3 beats, what do you see?
A paced, V paced.
A paced, V paced, A paced, V paced, A paced, V paced. So right there, you went through the simple steps of knowing what the atrium's doing, knowing what the ventricle's doing, figuring out what the device is seeing at every time, right? So just a stepwise approach. If you see what's going on in intrinsic rhythm, what the atrium's trying to do, what the atrial lead is trying to do, what the ventricle's trying to do, you'll figure that out perfectly. Make sense?
Gotcha. Yep, thank you.
Perfect. Good job. Let's see if I can do this. Okay. So Dr. Christian talked a little bit about this, but over sensing leads to under pacing, right? So if you think that there should be more pacing spikes and you don't see the pacing spikes on the strip, then you know there has to be over sensing happening, right? The device has to be seeing something so that it's inhibiting that complex. Anybody want to take this?
How about Aaron Richardson?
Oh my goodness, that's good.
Hey, how are you doing? I'm Aaron Richardson here. Okay, so what we've got here looks like we have an atrial beat, V pace, atrial beat.
When you say atrial beat, you mean what?
Oh, I mean, I'm sorry, intrinsic beat. Sorry.
So atrial sensed.
Right. A sensed.
So A sensed, V paced on the first beat.
Right. A sensed, V pace, A sensed, V pace, and then it looks like we're A sense again, but I don't see an actual V pace. We skip, and then we're back to A sense, V pace. So it looks like we're maybe, I guess, over sensing leads to under pacing. So I think we're just probably going on here. We just missed the ventricle beat.
So which lead is over sensing?
So I guess it would be. I guess it would be the atrial lead that's over sensing.
So remember, which
I'm
lead are
sorry,
you not getting
ventricular,
pacing of?
ventricular.
Huh?
I think it's the ventricular because it's thinking, oh, I saw ventricular waves.
So it sees
firing. Right,
something which
exactly,
it's
yeah.
not
So
supposed
that's
to
what I meant.
see, and then it inhibits, right?
Exactly.
So again, but if you notice, there's no atrial spikes anywhere. But you know this has to be a dual chamber device because it's tracking appropriately, right? So it's
Right.
the atrial lead is definitely sensing. You don't know if the atrial lead is pacing, but you definitely know the atrial lead is sensing because every A sensed is followed by a V paced, except in the middle where you don't see a ventricular paced. So again, you went through the same process of seeing A sense, V paced, A sense, V paced, and figuring out what the device is seeing. And then you figured out, hey, there's a problem with the ventricular lead. Make sense?
Let's talk about this for a bit longer. So someone had a little question before on kind of what is tracking. What does that mean? So this is kind of a nice example of we're seeing a ventricular pace after an atrial beat. So after every atrial beat, at least the first two, let's say, and the last two, we have a ventricular pace. So we're essentially tracking the atrium. We must be in a DDD mode because now when we're seeing a beat in the atrium, we're pacing in the ventricle. So remember that last D, remember the first D is for dual being atrium and ventricle. The second D is dual for atrium and ventricle. The third D is dual also, but it means inhibit as well as trigger. So inhibit would be if it senses a beat, it's not going to do anything. But triggered means if it senses a beat, it's going to fire. We don't use the triggered mode in a single chamber device. If you sense a beat, why would you want to pace a beat? But we use it in the dual chamber device where we sense a beat in the atrium and we trigger in the ventricle after our programmed AV delay. So in this case, we have a nice example of that we are sensing in the atrium, as Dr. Shakir said, and pacing in the ventricle, but that third beat doesn't pace in the ventricle. So we could say, well, gee, why is it not kind of triggering there? And it's because it must have sensed something in the ventricle. If it was under sensing in the atrium, then it would have fired in the atrium after that P wave. So we would have seen a pacing spike. Maybe we wouldn't have captured depending upon if the atrium was refractory, but then we would kind of get a beat in the ventricle. So this is a nice example of atrial sensing, ventricular tracking in a dual chambered pacemaker. Great.
Thank you, Ralph. Everybody's on the same page? We can go to the next one. They're only getting tougher from here. Okay. Under sensing, right? So under sensing leads to over pacing, right? So we said this before. So if you see too many pacing spikes, you know that, hey, the device is not seeing something, is not seeing the stuff, right? And that's what's going on. So if the local electrogram is small, the pacemaker will not see activity and will overpace. So you can actually program the sensitivity of the pacemaker. So that's why it's really important when the device goes in to make sure you have good, robust P waves, robust QRS. So you know the sensing is good. So you want more than 7, again, in the ventricle, more than 1 in the atrium, or 1.5 in the atrium. So that way you have room with the sensitivity to drop that fence down to make sure you don't have a problem with undersensing. One more concept. If the event falls in a blanking period, and we talked about blanking period where the device's eyes are closed and not looking, it's example of functional undersensing, right? So if something happens in that blanking period where you extend the blanking period for some reason and an activity happens there, that'll be functional undersensing. And the other hand, if the event happens in the refractory period, the device sees the event, right, but doesn't act upon it. And the blanking period, device doesn't even see the event. Okay. Who is going to help us next? Any other fellows out there that want to take it? I know there's some residents there too. Who wants to help me with this
I
one?
could try.
Oh, awesome.
So I see 5 QRS complexes. They have like a right bundle morphology. I think they're all natural complexes because the P morphology is the same in all 5 of them, and the PR interval is a little bit prolonged, but it's the same. So what I think is going on here is it's atrial sense, it's ventricular sense, and I think there is undersensing going on in 3 of associated with 3 of the complexes. So for some reason, I think the
So do you want to know, again, going back to the beginning,
Yep.
do you want to know what kind of pacemaker this is?
Yes, I would like to know.
No. So that's, remember, so you might as well ask all these questions, right? Before you go see the strip to figure out, hey, is this a dual chamber? Or is this a single chamber pacemaker?
I assumed it was a dual chamber.
Oh, go ahead.
I assumed it was a dual chamber.
You assumed it was a dual, and from there, how would you figure out? So let's say you presume, let's make it simple first. Let's presume it's a single. Let's presume that this is somebody coming in with syncope and the fellow put a TVP in the middle of the night.
Okay. So yes, if it's a single chamber, then it's also easy to understand. So maybe what's going on here is that you have this, you have a VVI if it's single, and in the first QRS complex, it's V-sensed and it's inhibited. And then in the second one, it might have become, it might have been V-sensed but triggered. I mean, sorry, not triggered, but basically the appropriate QRS complex is fired by the pacemaker spike. And then
to me, what I see is from here, you look across, you see the QRS is marching across the screen, and you see the pacing marching across the screen with no connection anyway. So I don't see anywhere sensing happening, right? So there's like no sensing happening. And if you look at the QRSs where the spikes are happening, like some of them happen actually like the second spike, the first spike happens before the second QRS. And there you should actually be able to capture the ventricle. So this lead has probably gone somewhere. So you have no sensing and you have no pacing, right? So it's under sensing. So it's not even seeing any of those events, right? Because it doesn't change. The rate doesn't even change. It's the same, whatever is programmed then, all the 3 spikes happening at the same time, whatever rate it is. And so the lead probably moved. Does that make sense?
Yes.
So here, when you have too many pacing spikes, remember that it's under sensing and it's not working.
Yeah, that makes sense.
Okay, keep going. And in this case, would you have, is it true non-capture? Is it functional non-capture? For the pacing spikes?
I know that the middle pacing spike functionally is functional non-capture.
Okay, so it could be functional in the middle, because again, it's still in the middle of the T wave. You may not necessarily get the ventricle may be refractory. On the other hand, the other 2 spikes, definitely they should have captured something. So in that case, there's true non-capture as well. Perfect, right? So you went through the same process, trying to figure out what type of device it is, what's the underlying rhythm, and what's the interaction between the 2.
All right, hang on here a sec.
Okay.
So this is a pretty complicated thing. It actually could be several different things, right? So the way that I would approach this is look at the strip and say, first of all, what is the underlying rhythm and can you tell what it is, right? So it looks like it's sinus rhythm with maybe a little bit of a generous AV delay, almost there, right? And kind of a rightish bundle or a widened QRS, right? But it's about a rate of around what? Around, 90 or so, okay? And what am I pacing at? What is my pacing rate? So it looks like 1, 2, 3, 4, a little bit more than 4 complexes. So maybe you're at a rate of around 65 or so, right? So why would you ever be pacing at a rate of 65 or so if your heart rate is 90? Right? So you must be under sensing. But the truth of the matter is, if it's a single chamber device, you actually don't know what the device is programmed to. It certainly could be VOO. If it's VOO, you do fail to capture the very first pacing spike because you usually see a QRS right after that. This would be functional non-capture because, as we said, it occurs in the T wave, but this is definitely non-capture because you would see a QRS after that. So it could be VOO or VVI would fail you to capture, fail you to sense, but could it also be an AAI pacemaker? So let's think about that. Well, okay, so it is certainly, if it's AAI, it's failing to sense this P wave. You wouldn't expect it to capture a P wave here because it's so close after it. The second spike, you would also be under sensing if it's AAI. Remember, an AAI is not going to see QRSs at all, but you are failing to sense the P wave. But what should happen there? Well, if it really is AAI with enough output that would appropriately capture, you would see a P wave there. And that would deform the ST segment. So that theoretically could be failing to sense and failing to capture in an AAI pacemaker as well. So this device, if it's programmed appropriately, if it's working appropriately, it's either a VOO or an AOO mode, and it's failing to capture in either of those modes because the first pacing spike should be capturing a QRS there before that rightish bundle beat. And certainly the last one should. And if it's an AAI, you wouldn't expect it to capture the first pacing spike, but you would expect it to capture the second one. Remember, the atrium is not refractory during the T wave. It's the ventricle that would be. So this is, sometimes it could be many, many possibilities, and that's why. And the question now coming saying, could it be a dual chamber with failing to capture and sense? Well, the answer would be no, right? Because if it was dual chamber and it failed to capture or sense, then we would see 2 pacing spikes, right? If it's failing to sense in that mode. So we're pretty certain that it's a single chamber, but quite honestly, we can't even tell just from looking at the strip if it's an atrial or ventricular one. Okay, so these are sometimes even tougher than we think, because it really is a lot of possibilities. If you start learning all the different modes that pacemakers have, it could even be more difficult. All right, how about go one more? Do you have one more case there for us?
I think I have a couple. We'll try to, I think I forgot my challenging ones. These are the easy ones. So I think I got a couple more that will be done soon. I know I hate to torture you guys at 9 o'clock at night. Let's see. So we went through these kind of basic principles for basic stuff, which is going on. And again, if we kind of go back, what's going on in the atrium, what's going on in the ventricle, what's the pacemaker seeing, what's the pacemaker doing? To go that same thing, right? So 1 pound of learning requires 10 pounds of common sense to apply it. So sometimes they'll be easy, sometimes they'll be challenging. So we're gonna go through a couple quick ones now. Okay, so what do you guys see?
V pacing.
V pacing, what else do you see? So let's say I tell you this is a dual chamber pacemaker. The V pacing is occurring at what? What rate is the V pacing occurring at?
About 100.
We have some folks saying about 150 or so.
Little faster than 100, right?
125.
Okay, fine. So if it's occurring, let's say at 120, what is, and if it's a dual chamber pacemaker, what's happening? It's occurring at it's pacing at the
Upper rate behavior.
upper rate. Perfect, right? So if it's pacing at the upper rate, there's only a few things that can be in the differential. What's the differential?
SVT.
Huh?
Some sort of SVT or AFib.
So it could be some atrial tachycardia where it's tracking this SVT inappropriate, and it's not necessarily sensing, it's not actually changing modes to DDI. So if it's an AFib or atrial flutter, you'd think that it would stop tracking that. So it's inappropriately tracking something, right? So you could actually reprogram the sensitivity to make sure that it's programmed correctly. So that's something you could do if you see somebody just going at 120 beats a minute all the time. What else could it be? Could be like a sinus tachycardia where it's just tracking whatever's going on in the atrium. And the third thing is?
We have some answer in the chat saying.
I have trouble seeing the chat. What's the?
Well, I'm going to tell you.
Okay.
So somebody's saying maybe it's something called PMT.
PMT, perfect, right? So if you want to learn anything, so if you see upper tracking rate, right? So something happening at the upper tracking rate, you always think of PMT. And for the bonus question, what do? You can put a magnet on it, right? It'll stop it. And what can you program? This is probably the only board question that they're going to ask you for cardiology boards. What do you extend?
PVARP.
PVARP, perfect, okay.
Lots of PVARPs in the chat, great.
Next one. I want to get you guys out on time. So this is a 71-year-old man with the history of an ICD who presents to the office not feeling well. So what do you see? Who wants to take this? Who's our gonna be an EP fellow soon? Anybody out there? Or wants to go into EP? Somebody take it. We got 5 minutes left. We got to finish on time.
How about Al?
Can take this.
Perfect. Take
We see atrial activity and ventricular in dissociation from each other.
Okay.
The ventricular activity is wide, complex.
Mm-hmm.
So this is just kind of a clear, complete heart block.
Perfect. So the A's are going separately than the V's. Anything else you see?
Yeah,
I
don't see
pacing or sensing?
I don't see any pacing.
Some of the old EKGs,
I don't see any pacing
see a
spike.
really small pacing spike, and it's sometimes not. It's a challenge to actually see. But if you look at V2, V3, you got this little small pacing spike. What's going on? Explain it. They got an ICD. Why are they
very
pacing?
well.
Why are they complete heart block? So what do you always want to know when you're looking at a strip? What kind of device do they have? Right? So this person has a
I'd like to know
single chamber ICD. And then what happened?
Mm-hmm.
So single chamber ICDs are programmed at?
ICD, it's probably programmed as VVI.
VVI.
And,
perfect. And the rate? What's the rate usually?
Yeah, for single chamber ICDs, the rate is usually in the 40s.
It's usually in the 40s because we're trying not to do ventricular pacing. So this person got implanted with a device, right? And then what happened? They went into complete heart block, and then they were just pacing in the ventricle, right? So you have to know what type of device they have. You have to know what the underlying rhythm is. And you go through the same process, you'll make the diagnosis. This was somebody who didn't have complete heart block, has a single chamber ICD, went into complete heart block, not feeling well, presents to the clinic pacing at 40. Make sense? You guys are good? Okay. My last one. Almost finishing 2 minutes before time. I always try to finish on time for you guys. So what do you see? So can we get this one we can put in the chat box. What is that beat? Is it A? Is it a paced beat? Is it B? Is it a fusion beat? Is it C, a pseudo fusion? Is it D, a pseudo fusion? Or E, I have no idea. It's way too late at 9 o'clock to be looking at these EP strips.
Got several B's, a C, a D, an E. Somebody's between B and E.
So we're gonna go through this, right? So paced beat, right? A paced beat meaning you have, so for example, if you look at the left part of the strip, you have a spike and then you have atrial, the P wave following that atrial spike in the first beat. So it's A paced, V sensed. So that first beat is A paced, V sensed. The second beat is A paced, V sensed. The third beat, A paced, V sensed. Fourth beat, A paced, V sensed. Fifth beat, A paced, V sensed. The next beat is a PVC that comes in early. And then the next beat, if you look carefully, is an atrial pacing spike. And then you have a native kind of QRS coming through. And then you have a ventricular pacing spike, and then you have something off to the races. So look, a paced beat, you should have a pacer spike and you should have depolarization of the chamber. A fusion beat is like fusion food, right? So it's between a paced beat and what a normal QRS looks like. So if you combine the two and the beat looks like it's in between, that's a fusion beat. A pseudo fusion beat is a paced beat, right? And a QRS which sneaks through. So a normal looking QRS followed by a ventricular paced beat is a pseudo fusion because it's not a paced beat. The QRS is not wide. It's not a fusion beat where it's kind of in between a native one. So it's a native beat followed by a QRS spike. But in this case, there's an atrial spike followed by a native QRS. So in this case, this is a pseudo fusion beat. So we don't make up these terms in EP. They've been there. They're kind of neat, but for you guys remember, it's really cool. And you've learned these new terminology tonight through Dr. Krishnan's talk and through our talk, and hopefully some applications, right? So it's kind of fun to know the terms. You can throw it out with your friends when you go tomorrow around. Remember, your baseline information is very important prior to attempting rhythm interpretation. Know the device, know the rhythm, that'll help you. Know your pacemaker terminology, right? So if you don't know any of these terminology stuff, you're not going to be able to figure out what's going on. And use that same stepwise approach that even when Ralph's looking at some of these tracings going through, he's seeing how he's doing it the same way over again and assessing what's going on in the pacing function, what's going on in the sensing function. And that is the last slide.
All right. Well, thank you. There was one quick question. I'm just going to say that again, a complex strip to end on. And we do know that it's pseudo fusion because we know that that has to be an atrial complex because then we get that ventricular pacing spike after the AV interval. And then the question came out, why were we off to the races there? And that's because we kind of did an EP study on this guy. This person looked to me like they're inducible. So we actually gave an early beat because it kind of came after a QRS. So we kind of gave they were inducible with single extra stimuli, okay, if you will. Looks like a single beat. Can you go back to that one?
Sure.
So it looks like that's kind of what we had there. To me, it looks like then they were off to the races in a ventricular tachycardia. So it looks like this person's going to graduate from a pacemaker probably to an ICD, and we'll learn more about that next week when we learn about ICD. So again, I want to thank the speakers for 2 superb talks. Again, this is complicated, so we invite you to tune in for the next couple of sessions and to continue on the learning. So it takes a while, it's learning a new language, but you guys are all doing very well with 2 excellent talks. Again, I'd like to thank ZOLL, Mitzi, Yvonne, Cheryl, and all the ZOLL folks for their sponsorship of this great fellow educational opportunity. And I'd like to see you guys all in 2 days, hopefully. And thank you all, and good night.